In patients with advanced liver disease, renal dysfunction becomes not only a marker of severity, but a major determinant of outcomes. Please welcome on stage Dr. Raja Asif. So his talk titled, When Liver Fails, the Kidney Follows, Navigating Hepatorenal Syndrome in Nephrology. So please join me for welcoming Dr. Raja Asif to the podium.
Thank you very much. It's always nice to be here at the forum of Pakistan Society of Nephrology. Since I belong to Pakistan Kidney and Liver Institute, when Dr. Sajid called me and said he's giving me a topic which has liver and kidney both in it, so I had no excuse to say no to it. So, let's talk about it. And also Dr. Halim, so this is not a gurda or heart. We have dil or jigar also is there. So, yeah, jigro gurda is there too. So let's talk about it. So I'll start with a case scenario so that we can better understand the pathophysiology of this disease. 41-year-old male with history of hepatitis C virus-related cirrhosis. He was diagnosed last year. He presented to the emergency room with altered mental status and lethargy. On exam, he was jaundiced. He had some dried blood present at his nares. And in the emergency room, his vitals were, his blood pressure was soft, 100 by 55, pulse 112, temperature 99 degrees Fahrenheit. His abdomen was grossly distended, most likely at ascites. And other significant finding on the history was he had diarrhea because he was taking lactulose, and he had poor oral intake as well. Now, the labs in the emergency room, his hemoglobin was 5.9. His bicarb was 15, his serum creatinine 3.02, and you can see on the side it's written his baseline creatinine was 1.5, that was a month ago. And you can see his albumin was 1.3. His WBC is raised 17.8. Keep those numbers in mind. Further testing is urine, which was obtained actually after putting a Foley catheter. Urine sodium was less than 10, urine potassium was less than 15, his fractional excretion of sodium FeNO was less than 1. He had some blood on the urinary and protein, and again the sample was taken after he had the catheter. This was the real case, normal sized kidneys and no hydronephrosis. So can this patient have hepatorenal syndrome? You see, you looked at the history. The answer is possibly yes, but remember, he also had diarrhea because he was taking lactulose, and his blood pressure was soft because probably he was bleeding. So this could be pre-renal AKI as well. This could be ATN. So the idea here is you cannot label hepatorenal syndrome to somebody just on these history and examination as well as these labs. So you have to go a little further to figure this out, and I'll tell you how. So this study is a retrospective cohort study, was done on 2,000 patients. These patients were cirrhotics and had AKI, and they figured out that 45% of these patients had pre-renal AKI, 31% had ATN, and hepatorenal syndrome was in 12% of the patients. But remember, this study was done in US, and as we know, in our country, the burden of chronic liver disease and end-stage liver disease is way more than in Western countries, so probably hepatorenal syndrome incidence is more in our country. But still, if you look at it, mostly the pre-renal ATN was the cause in this study. Now, what is hepatorenal? It's a form of AKI that results from severe renal vasoconstriction without the evidence of structural kidney damage. Okay, how does this happen? Let me explain that picture to you. When you have cirrhosis, there is obstruction to the portal flow, cause portal hypertension, and that portal hypertension actually puts some stress on the splanchnic circulation, and that causes release of vasodilators, which is nitric oxide and prostaglandins. These vasodilators actually cause vasodilation and pooling of blood in the splanchnic circulation, leading to decrease in effective arterial blood volume. Okay. And what happens with that is, when you have a decrease in effective arterial blood volume, there is a compensatory increase in cardiac output, tries to maintain the hemodynamic stability, and at the same time, when the condition worsens further, there's activation of the renin-angiotensin-aldosterone system, release of catecholamines, as well as arginine vasopressin. All these mechanisms ultimately bring severe renal vasoconstriction and decrease the GFR as well as acute kidney injury. Another mechanism which is described is there is increased bacterial translocation from the gut, and these bacteria, they release inflammatory cytokines, cause direct kidney injury. So these are the mechanisms which cause hepatorenal syndromes. Now, if you look at this picture, there is when you have a compensated cirrhosis, cardiac output tries to increase to just maintain that hemodynamic stability. But when the things go out of control, such as decompensated cirrhosis, at that point, those vasodilators play their role and increase renin-angiotensin-aldosterone system, cause further and further deterioration by retaining more sodium and water, and causing by angiotensin 2, it causes direct vasoconstriction in the kidneys and leading to renal failure. This picture again tells us the same thing. You see, initially, when you have when you have compensated cirrhosis, the cardiac output tries to increase a little bit, try to compensate that decreased blood volume, decrease in effective blood volume. But as the condition worsens, the cardiac output actually decreases, and there is a term for it called cirrhotic cardiomyopathy, in which there is a diastolic dysfunction. And again, when you see there are ascites and decompensation, the degree of RAS system and SNS goes so much high that it ultimately causes vasoconstriction and hepatorenal syndrome. Now, the hepatorenal syndrome is two types. Type 1 is pretty aggressive. Usually, you have doubling of serum creatinine in less than 2 weeks, and if you do not treat this, there's very high mortality in these patients. Type 2 is slowly progressive disease. Usually, these patients have ascites which are resistant to diuretics, and their serum creatinine slowly goes up to more than 1.5. It has slightly better prognosis than type 1. Now, what is the criteria? How would you diagnose hepatorenal? So you have to have cirrhosis with ascites and acute kidney injury, but there should not be any clinical signs of shock. Patient should not be on any NSAIDs, any nephrotoxic drugs, no diuretics, and there should be absence of parenchymal disease. But again, exceptions are always there, because patients who have diabetes, they might have some degree of proteinuria, so you have to look into that. And the main thing is there is no response to AKI with 2 consecutive days of volume expansion with IV albumin after stopping all the diuretics and nephrotoxic drugs. When there is no response, this is most likely hepatorenal syndrome, because you need this criteria to make a decision, because you're going to use the vasoconstrictor therapy. You can't use that in pre-renal or ATN. Now, FeNA is also usually low in hepatorenal syndrome, but this study demonstrated that when they did the biopsy on cirrhotic patients with AKI, 90% of these patients also had FeNA less than 1, despite their biopsy evidence showed ATN versus glomerular pathology. So that's why FeNA is not always indicative of hepatorenal syndrome. It has been omitted from that diagnostic criteria, because this is a question a lot of time people ask about it. Now, these are the very important factors. These factors need to be identified and treated, because, I know some centers, especially in US, I'm sure in Pakistan also, when you have cirrhosis and you come to the hospital with AKI, even if you're asymptomatic, they do paracentesis or diagnostic tap to figure out if they have any evidence of SBP, because if you treat that early, you can prevent these patients going into the hepatorenal syndrome. So this is very important to know. Any kind of infection actually can precipitate hepatorenal. Then if you have gastrointestinal hemorrhage, you have to treat it timely and aggressively. And large volume paracentesis, when you do, you have to use albumin, because if you don't use albumin, that can also precipitate hepatorenal syndrome. Again, as I said before, hepatorenal type 1 has a very bad prognosis, 2-week mortality as high as 80%, and there's a 10% survival in 3 months. So this is an aggressive disease and needs to be addressed as soon as possible. Type 2 is slightly better, and its mean survival is 6 months. This graph also telling the same thing, because if you look, type 1, the prognosis is weeks to months, and type 2, people survive a little longer. Now, how do you treat these patients? This is very important. The problem is the main treatment is liver transplant. In Pakistan, as I was discussing with Dr. Zaid Nabi also, this is a big problem. We don't get the liver right away, and there are few centers who do. Definite treatment is liver transplant, and medical management include those vasoconstrictors, which we'll talk about it. Renal replacement therapy has to be done in selected cases, and I'll tell you which cases we should do the renal replacement therapy. Now, what options we have? We have terlipressin. If that's not available or it's contraindicated, then octreotide and midodrine can be used. If the patient requires ICU, then norepinephrine. all these vasoconstrictors need to be used with IV albumin unless there is evidence of volume overload or pulmonary edema. Now, when I was a fellow in nephrology in US, there was no terlipressin. So we were using octreotide and midodrine all the time. So I have pretty good experience with that. And norepinephrine mostly we were using because these patients were sick to begin with and they were in ICU. Now this study, let's talk about these vasoconstrictors and how to choose and when to choose. So this study actually compared terlipressin plus albumin with midodrine and octreotide plus albumin, the treatment of hepatorenal syndrome. And you can see in the terli group, the 1 month survival was 70%, and it's almost the same survival in both the groups. But the long-term 3-month survival was better in terli group. So that's why terlipressin is better if you have available to use. Now, this is a very important actually paper, and it came around the time when terlipressin was being approved by FDA in US, and they assessed the, they did this phase 3 trial was conducted to assess the safety and efficacy of terlipressin, and they saw the endpoint was reversal of hepatorenal syndrome, and the group which got terlipressin had significant good positive findings and of reversing of hepatorenal syndrome than the placebo group. But the problem in this study was this: the side effects. A lot of patients had these respiratory side effects, and few actually people died, and it's thought that that was mostly from aspiration pneumonia and bacterial pneumonia because these patients are sick to begin with, but also some patients had pulmonary edema as well. So that is something we have to look into. That's why terlipressin is contraindicated in patients who have hypoxia to begin with. They're those patients who have saturation less than 90 on room air, or if they have worsening of their respiratory symptoms. If they have significant vascular disease or ongoing myocardial or peripheral or mesenteric ischemia is going on, and these patients, terlipressin should not be used, and you use the other options. If you have pretty advanced kidney disease like creatinine more than 5, or if you have 3 organ failure, then the use of vasoconstrictor actually, especially the terlipressin, should be decided on case-by-case basis because probably it's not going to help at that advanced disease. Now, for how long you will treat these patients? You will treat for 14 days, and the treatment should be discontinued if there is no improvement in serum creatinine at all after 3 days of vasoconstrictor therapy with IV albumin. And if creatinine improves to within 0.3 milligram per deciliter of their baseline, that time also we should consider stopping the treatment. If patient develops serious side effects from the drugs, or if the kidney replacement therapy need to be initiated at that point, there is no need to continue the vasoconstrictor therapy. There is less likely chance that patient will recover from that disease. And yes, if patient gets the liver transplant, of course, we have to stop the vasoconstrictor therapy. Okay, so this should be, renal replacement therapy should be actually, considered in those patients who are awaiting liver transplant. Because remember, these patients are very sick to begin with. They're hypotensive, the liver is not working, they're coagulopathic, and, coagulopathic, and then when you do renal replacement therapy in these patients, there are complications. They can have bleeding, they're difficult to do dialysis in these patients because of low BP. So again, should be reserved for those patients where we are bridging them for liver transplant. Otherwise, it has to be selected on case-by-case basis. Tips, few words about tips. It's not indicated. It definitely lowers some portal pressure, but it has more problems than benefit. You can have procedural complications, and also 20 to 30% of cases it precipitates hepatic encephalopathy. So try not to use them. Use it unless there is there is an indication for it. Now, liver transplant, which is the definite treatment. So how would you evaluate? So you have type 1 hepatorenal syndrome. You evaluate the patient for liver transplant. If they are candidate, you should prioritize these patients on transplant list. Start the vasoconstricting therapy with terlipressin or other vasoconstrictors, and evaluate for improvement of kidney function. And stop the therapy, of course, if there is improvement after 15 days, but keep the same pre-treatment MELD score. That's important. Don't just put them into the category again because they have improved. No, we have to keep the same MELD score because they need the transplant as soon as possible. And if they do not improve with the vasoconstrictors, then these are the patients which we should consider renal replacement therapy, because ultimately they're going to get the renal transplant. But those patients who are not candidate for liver transplant, vasoconstrictors therapy should be individualized because of the problems I told you before, and renal replacement therapy also should be reserved for particular cases. Now, type 2, usually these are the patients who have refractory ascites and they are resistant to diuretics. Again, evaluate these patients for liver transplant. If they are candidate for liver transplant, you have to do large volume paracentesis in these patients with albumin and give them antibiotic prophylaxis. Keep evaluating their kidney function. If their serum creatinine keeps on increasing, you should treat them with vasoconstrictors, because again, they are the candidate for liver transplant. And those patients who are not candidate for liver transplant, or the transplant is not available, then just by doing the repeated paracentesis with albumin and antibiotic, we have to handle those cases. Now, simultaneous kidney liver transplant, the data from organ procurement and transplantation network has demonstrated that patients who have baseline creatinine more than 2, probably CKD4 or 3B, these are the patients get more benefit from liver kidney combined transplant rather than giving them only liver transplant. So what are the indications for simultaneous? Patients with end-stage renal disease, of course, they will get both. Patients with CKD with GFR less than 30. Okay, this is their baseline GFR I'm talking about. Patients with AKI and hepatorenal syndrome, if they stay on dialysis for more than 6 weeks, they qualify for simultaneous kidney liver transplant. And patients with AKI and GFR less than 25 for more than 6 weeks, documented in medical record, these are the patients also candidate for liver and kidney simultaneous transplant. I think that's it. Thank you. Any questions and comments? Let me ask you a question. Otherwise, I was about to ask Dr. Adil a question. Thank you.
सवाल मेरा ये है
जी जी
बेटे आपको सबको पता है कि ओल्ड डेफिनेशन क्या थी आई वुड से दैट इज स्टिल वेरी वैलिड pre-renal failure when all other causes of pre-renal failure have been ruled out यही मैसेज दिया ना that still holds true अब जो था very low urinary sodium उसको as one of the criteria has been taken away कि उसकी वैल्यू कुछ साबित नहीं हो सकी मेरा रेजर क्वेश्चन है बायोप्सी हुई उन पेशेंट में उनमें से कुछ में ATN मिल गया यही है ना स्ट्रॉन्ग पॉइंट के ये इंक्लूड नहीं होना चाहिए लेकिन मैं उनसे क्वेश्चन करता जिन्होंने बायोप्सी की थी और इंटरप्रेट किया उसके बेस पे उसको रूल आउट किया कि भाई अगर अब पेशेंट्स हेपेटोरेनियल सिंड्रोम है रिकवर नहीं करता अगर वो मरता नहीं तो मोस्ट ऑफ देम विल डेवलप उनको ATN हो जाएगा जब ATN हो जाएगा तो वो जो प्री रीनल है ना एजोटीमिया वेरी लो सोडियम दैट विल होल्ड ट्रू इवन इन प्रेजेंस ऑफ ATN वो रहेगा तो मुझे हैरानी है कि उन्होंने किया दूसरे बेटे बात सुने जब ATN हो गया है तो ATN की कोई ना कोई तो मैनिफेस्टेशन यूरिन सेडिमेंट में होनी चाहिए कि नहीं इसमें यूरिन एब्सोल्युटली नॉर्मल होता है व्हेन यू लुक एट द माइक्रोस्कोप हेपेटोरेनियल सिंड्रोम वालों में कुछ नजर नहीं आता कोई नॉर्मल होता है अच्छा ATN हो गया तो फिर बॉडी कास्ट और दूसरे आपको नेक्रोटिक एपिथेलियल रिजल्ट मिलेंगे आपको ये है मेरा आई डोंट नो व्हाट वुड यू से अबाउट इट
असल में एक्चुअली मैंने ये नहीं कहा कि ATN जो फीना जो है वो लो हेपेटोरेनियल सिंड्रोम का पार्ट नहीं है उसमें लो होता है मगर उस क्राइटेरिया से हटाने का मकसद यही है कि बहुत से पेशेंट्स में अगर आप बाकी चीज़ें नहीं देख रहे सिर्फ फीना के ऊपर डिसीजन मेकिंग कर रहे हैं तो वो भी लो हो सकता है दैट्स व्हाट द पॉइंट आई वाज ट्राइंग टू मेक और बिफोर दैट वाज आई वाज ट्राइंग टू से
आसिफ आपका पॉइंट था कि हेपेटोरेनियल सिंड्रोम में
जी
ट्रीटमेंट इज़ लिवर ट्रांसप्लांट ठीक है जी और किडनी क्योंकि नॉर्मली यूरिन नॉर्मल होता है डैमेज नहीं होता तो ख़ुद बहुत ठीक हो जाती है ठीक है तो ये इंडिकेशन स्पेसिफिक आपने कुछ रखी हैं कि जिसमें इन स्पाइट ऑफ हेपेटोरेनियल सिंड्रोम एक लेवल से जब चीज़ क्रॉस कर जाए तो दैन लिवर और किडनी ट्रांसप्लांट दोनों साथ हो सकते हैं
जी
लेकिन रूटीन में तो मेरा लिवर ट्रांसप्लांट काफ़ी नहीं है
نہیں سر اس کی کچھ انڈیکیشنز ہیں نا. اب جس کو کڈنی ڈیزیز پہلے سے ہی ہے,
وہ تو ایک سیپریٹ ایشو ہے نا.
ہاں جی,
کیونکہ ہیپیٹورینل میں آپ نے پہلے ڈیزیز تو ایکسکلوڈ کرنی ہے تب ہیپیٹورینل ہوگی. اگر اس کو پہلے سے کڈنی ڈیزیز ہے تو ہیپیٹورینل تو ہوئی نا.
مگر گائیڈ لائنس ہیں کہ اف یور AKI stays for, جیسے میں نے بتایا, GFR less than 25 for more than 6 weeks.
یہ پاسبل ہے, یہ تو پاسبل ہے. اگر آلریڈی CKD ہے پھر تو AKI
نہیں, اگر بعد میں بھی AKI ہیپیٹورینل کی ایک میں نے جو سلائڈ بتائی تھی اس میں ایک انڈیکیشن یہ بھی ہے 25 GFR 25 ml سے اگر نیچے رہتا ہے 6 ہفتے لگاتار تو آلریڈی آپ کے کڈنی میں وہ بیٹر ہے کہ آپ اس کو ٹرانسپلانٹ کر دیں, کیونکہ کڈنی کا ڈیمیج مطلب ہے وہ CKD لائکلی ڈیولپ ہو چکی ہے. وہ پوائنٹ ان کا یہ ہے.
دوسرا ہاں اسی طرح کا ایک الٹا ریورس کوشچن ہے جو مجھے نہیں سمجھ آئی کیسے ہوتا ہے.
Dr. Halim, your point is right to some extent. It's a functional condition. وہ functional
You have to exclude all other causes.
وہ peripheral vasodilation ہو جاتی ہے, اس کی وجہ سے سارے نیورو ریگولیٹری ہارمونز ریلیز ہو جاتی ہیں, نائٹرکس آکسائڈ, and it is really a function which causes AKI. So this notion which you are saying is actually has been challenged. The criteria what Asif has described is the present UNES criteria for a simultaneous liver kidney. They said that basically functionally the kidneys are normal. So what they did that the patients who have been on dialysis dependent for 6 weeks, they did only liver transplant for these patients. And you believe me कि about more than half came off dialysis just by supplementing the liver. Then they find out that the patients on these criteria, if they did kidney transplant, and after the kidney transplant, when they did the DTP scans for all the kidneys, all the 3 kidneys were functioning. So what now they have put a safety network, that if the patient in that subcategory, CKD 25 ml GFR, 30 ml GFR, but has an AKI or is an AKI, normal renal functions before, developed hepatorenal, precipitated by infection, precipitated by SPP, becomes dialysis dependent, just give a liver that. Kidney does not remain, the patient remains dialysis dependent post liver transplant for 2 to 3 months, prioritize the list. That patient will go on the top for the kidney list and he will get the kidney. So actually you are right in that concept that it's a functional condition, and you remember and know that kidney is how important an organ is. That if you give that kidney to a person where it is not required, a 10-year-old may be waiting for another kidney for his life. That will be a life-saving for, plus supplanting a kidney to somebody who might not require.
اس میں ایک ریورس کوشچن ایک اور ہے, آپ نے بھی پڑھا ہوگا کہ جی یہ کڈنی چونکہ فنکشنلی ایب نارمل ہوتی ہے, انوائرمنٹ میں پرابلم ہوتا ہے, اف یو ٹیک دس کڈنی اینڈ ٹرانسپلانٹ ٹو اینی باڈی تو اٹس اوکے. تو لیکن کرتے کیوں ہیں یہ مجھے سمجھ نہیں آئی کہ کس طرح کریں گی. لیکن یہ کڈنی
that experiment has also been done in FSGS patient.
جی بالکل.
A person who develops a recurrent FSGS, nephrectomy done and transplanted to a polycystic kidney disease patient, and another case report transplanted to a diabetic patient, everything went away.
جی any other questions, comments please. آپ کچھ
We heard about basically how difficult dialysis can be and challenging.
Yeah.
Do you practice liver dialysis in, کیونکہ آپ لوگ کافی دیکھتے ہو لیور اور ہو, تو میں نے کہا جیز بیٹھے ہوئے ہیں, they need to know basically is there a provision of that, or do you recommend basically کہ ہونا چاہیے ایسے پیشنٹس البومن ڈائیلسس؟ What do you do?
اس میں مطلب یہاں پر پرابلم پاکستان میں تھوڑا سا ہے, لیکن CVVH اور CVVH-T can be considered because these patients are hypertensive and in ICU setting they can have that. That is little better than actually doing dialysis with albumin.
مارس تو سر نثار ہمارے پاس ہے نہیں, ٹھیک ہے, لیکن ایک چیز بڑی جو آصف کی بہت امپورٹنٹ ہے نا پی جیز کے لیے, وہ یہ کہ ہمارے پاس نا آئی سی یو میں بہت زیادہ یہ پیشنٹس آ جاتے ہیں ACLF3. تو یہ جو پوائنٹ میں بار کرنا چاہتا ہوں کہ ان میں ٹرلی پریسن نہیں دینی, ٹھیک ہے, وہ بالکل دیٹ واز این ایکسکلوژن کرائٹیریا ود ایڈوانس رینل فیلئر. اب وہ یہ کہ ہم لوگ نیفرولوجسٹ اتنے بزی ہو گئے تو سم تھنگز آر ان دا ہینڈ آف دا ہیپاٹالوجسٹ, تو وہ ان کے ہاتھ میں چلے گی تو وہ اٹس اے ویسٹ. پلس ایک ٹائم ٹیسٹڈ ٹرائل ان کو ڈائلسس کا اگر دینا ہے تو ٹھیک ہے, مطلب دے آر سو سک, دے ول بی انٹوبیٹڈ وینٹیلیٹڈ ورکنگ ان اے لیور سینٹر, ان کا ڈونر کوئی نہیں مل رہا ہوتا, سب کچھ نہیں ہے. تو اف یو وانٹ ٹو گیو اے ٹائم لمیٹڈ ٹرائل کوئی 1 ویک کا دے دیں, लेकिन बाद में फिर उसको पैलिएटिव केयर कर दें, वरना कि हमारे
हाँ
पास
जी।
इतने डायलिसिस सेंटर्स नहीं है जो वो हम उन रिसोर्सेज को उन पेशेंट्स के लिए यूज़ कर सकें।
ऐसे ही है सर। यूएस में भी जो है वो बेसिकली जो लोग कैंडिडेट नहीं होते उनको डायलिसिस अगेन हमें इनिशिएट करना पड़ता है, और बट अल्टीमेटली वी हैव टू इन्वॉल्व पैलिएटिव एंड देन फैमिली डिस्कशन एंड टेल देम द प्रोग्नोसिस, और उस तरफ लेके जाना पड़ता है। तो राइट अवे वो यू नो दीज आर डिफिकल्ट डिसीजंस। या
सर मेरा डॉक्टर आदिल से एक क्वेश्चन है, बिकॉज फ्यू सेंटर्स दे डू सिक्वेंशियल लिवर किडनी ट्रांसप्लांट। आपके सेंटर, बिकॉज प्रॉब्ली हाईएस्ट नंबर ऑफ ट्रांसप्लांट्स, लिवर ट्रांसप्लांट्स आर डन इन योर सेंटर, तो ये जो अभी कॉन्सेप्ट सर हलीम ने बड़ा ज़बरदस्त जो एक रेज़ किया, आप लोगों का कुछ एक्सपीरियंस है कि ऐसे पेशेंट दोज यू वर थिंकिंग कि ये लिवर किडनी बोथ दे नीड बोथ लिवर किडनी ट्रांसप्लांट, एंड देन यू डिड बिकॉज द सेंटर यू डोंट हैव द किडनी, यू जस्ट डिड द लिवर ट्रांसप्लांट, क्योंकि नंबर आपका बहुत ज़्यादा है, तो उसमें से कितने ऐसे पेशेंट थे जिनको आप समझ रहे थे दे नीड लिवर किडनी ट्रांसप्लांट, बट लेटर ऑन द किडनीज वो चल पड़ी या कुछ फंक्शनल उनका स्टेटस रिवर्स हो गया, क्योंकि सेंटर टू सेंटर भी तो वेरी करता है ना, तो इसमें आप लोगों का एक्सपीरियंस क्या है?
जाहिर इसमें डायलिसिस वाला पेशेंट तो कोई नहीं है, लेकिन मुझे इफ़ आई गेट द हिस्ट्री ऑफ दिस पेशेंट्स, देयर आर रॉक सॉलिड नॉर्मल रीनल फंक्शंस बिफोर, then he gets admitted, gets optimized, gets a donor and gets a liver transplant. अगर उसकी creatinine 4-5 भी है, we go directly for the liver transplant and then we manage the patient along with the hepatologist, ICU and that. And believe me, all of them have become better. But you have to document a normal rate. Where we get stuck now, we don't have a baseline creatinine. Patient is
Yes.
known diabetic, which is the usual history.
That's true.
Patient
That's
is known diabetic for 10 years. There's no baseline creatinine. He's come with a 3 creatinine. He has a bit of proteinuria. Proteinuria and diabetic kidney disease will be present with normal renal functions.
True.
That's not an indication. Then he's some component of HRS. Then we do a biopsy in this patient. Then we document that glomerulosclerosis is more than 40%. And IFTA is more than 40%. And you have to really get a good histopathologist on your heart, because this IFTA scoring I have found in Pakistan so much variable. And then you make your decision according to that. If your creatinine is 3, if your GFR is steady, GFR is less than 30, and your IFTA is more than 40% glomerulosclerosis, then we do triage, Zahid, these patients for combined liver and kidney transplant. The other important points, don't be surprised by the histopathological findings coming in these liver patients. I had a patient with almost borderline renal functions, and he had IgA nephropathy. Probably it was a secondary IgA nephropathy. And the biopsy was looking very bad. And he had 2 to 3 grams proteinuria. Another one with a membranoproliferative pattern of injury. And creatinine was 2, but there was no IFTA, no glomerulosclerosis. About that, all the glomeruli were normal, but these findings were there. We went ahead with the liver transplant. Even the proteinuria went, renal functions came to normal.
हम सारे डिफरेंट सेंटर्स में काम कर रहे हैं ना, बिकॉज वी कम अक्रॉस पेशेंट्स, तो सिर्फ ये बता दें कि जैसे हम वी हैव अ पेशेंट वी नो इज बेस लाइन क्रेटिन वाज नॉर्मल एंड ही इज़ अ पेशेंट ऑफ सिरोसिस और डीकम्पनसेट कर रहा है, डोनर उनके पास है, PKLI में कोई ऐसा हेल्पलाइन नंबर या कुछ ऐसा सिस्टम है जहाँ पे हम इस पेशेंट को भेज सकें इमीडिएटली फॉर ट्रांसप्लांट, इस किस्म के पेशेंट जो स्पीड अप हो जाए उनका ट्रांसप्लांट? जी ज़रा काइंडली बता दें।
I'm ready to cooperate. तो वो लिवर की टीम का मुझे एग्जैक्टली इस वक्त तो नहीं नंबर, लेकिन मैं एग्जैक्ट कोऑर्डिनेटर टू फॉर दीज पेशेंट्स, एंड वी डू गेट दिस ALF transfers all around acute liver failure transplant, and the condition sometimes we have to put these patients on CRRT, and they go into OR on CRRT, the acute liver failure. But we know documented that previously their renal functions, their kidneys have been perfectly normal.
Actually, one of my patient, I sent that patient to you, who we are planning for combined liver kidney transplant.
Yes, this is an important point also, that some patients are, for example, I just received a referral. There are patients with ESRD, and they are cirrhotics, but they are not decompensated liver disease.
Yes.
They have no portal hypertension. So if you educate the patient, counsel the patients, they can go only for kidney transplant. And down the road, if they get decompensated in 5 to 6 years, they can get a liver after that.
True.
But because they don't need the liver at that time, if they have no portal hypertension, the hepatic to portal vein gradient is normal.
जी प्रोफेसर तुफैल।
बेटे ये जो क्वेश्चन है या कमेंट है, इट्स नॉट रिलेटेड टू द टॉपिक, ये जरा साइड क्वेश्चन है। किताबों में लिखा है और हम पढ़ाते हैं स्टूडेंट्स को कि जब पेशेंट को किडनी प्रॉब्लम भी है एज ए रिजल्ट ऑफ लिवर प्रॉब्लम, तो यूरिया जो क्रेटिनी रेशियो है वो डिस्टर्ब हो जाती है। चूँकि यूरिया लिवर में बनता है, क्रेटिनी वहाँ नहीं बनती। यूरिया उस हद तक राइज नहीं करता जैसे क्रेटिन कर रही है, तो बनती है मतलब। लेकिन मेरी ऑब्जर्वेशन ये है कि ये इट्स नॉट ट्रू। हम क्वेश्चन नहीं करना चाहते, यूरोपियन का चूँकि ज़हनी तौर पर हम गुलाम हैं। ये क्वेश्चन मैंने पूछा प्रोफेसर जवेद अकरम साहब को, ही गेव ए प्रेजेंटेशन ऑन लिवर फेलियर, ये 3 साल पहले की बात है। तो मैंने कहा जी किताबें भी यही कहती हैं जो आप फरमा रहे हैं, मुझे बताओ कि हैव यू सीन एनी पेशेंट जिसमें यूरिया वाकई प्रोपोर्शनली बहुत डाउन हो एज कम्पेयर टू क्रेटिनिन? कहते नहीं। फिर मैं कहा काम आप तो ये टीच ना करें, मतलब बेटे आप ध्यान रखना, अगर है तो मुझे बता दें। कम से कम मेरे वो बैठे मेरे फेलो आप असिस्टेंट प्रोफेसर बन गए हैं, जब मैं वहाँ था तो मैं यही कहा करता, किताबें ये कहती हैं लेकिन आई स्टिल हैव टू सी ए पेशेंट जिसमें यूरिया आउट ऑफ प्रोपोर्शनली डाउन एज क्रेटिनिन। अगर नहीं तो ये बड़े ध्यान रखना, ये गलत है मतलब।
नहीं तो फिर आप एक्सप्लेन कैसे करेंगे जब लिवर काम नहीं कर रहा,
हाँ
तो यूरिया नहीं
वो बात ही समझते। मैं कहता हूँ किताबों में लिखा है इट मेक्स लॉट ऑफ सेंस, बट प्रैक्टिकली इट्स नॉट ट्रू। अगर है तो मुझे बताना, आपके पास नंबर मेरा है।
नहीं, मैं मैकेनिज्म पूछ रहा हूँ ना आपसे, मैकेनिज्म मुझे बताना कैसे पॉसिबल है।
हाँ हाँ तो उसी की बात कर, हम उसी की बात कर।
नहीं डेफिनेटली एडवांस डिजीज की बात हो रही है ना, जबकि लिवर फंक्शन
मैं एडवांस की बात कर रहा हूँ कि वहाँ भी मैं नहीं देखता, सच्ची बात।
चलो ऐसी और ना देखेंगे, और ना
कोई नहीं इसकी।
अच्छा, इसमें एक इम्पॉर्टेंट पॉइंट ट्रेनीज के लिए भी है कि लिवर के पेशेंट्स में क्रेटिनिन से जीएफआर ईजीएफआर निकालने की कोशिश ना करें। दीज पेशेंट्स आर सार्कोपेनिक, ऑल दिस ईजीएफआर formulas do not work. The only formula which works is a Grail equation. You can try, or you can do a DTPA scan provided the GFR is more than 30, because these nuclear scans, as Dr. Tufail know, everybody is fond of doing nuclear scans. They do not work in CKD4.
Any other question, comment? Thank you.
Thank you.
Thank you so much, Dr. Raja Asif, for your insightful lecture on navigating HRS in nephrology. Your expertise and clarity greatly enhanced our understanding of the subject. We truly appreciate your contributions to the cause. It is now my pleasure to introduce our next speaker, Assistant Professor Dr. Adil Ibad, a highly respected nephrologist and expert in renal diseases. Dr. Ibad currently serves as a consultant nephrologist in Shifa International Hospital and has contributed extensively to advancing the field of nephrology, particularly autosomal dominant polycystic kidney disease, one of the most common inherited kidney disorders affecting millions worldwide. With its progressive nature, multi-system involvement, and complex management, autosomal dominant polycystic kidney disease requires a nuanced and evidence-based approach, something Dr. Ibad has consistently championed through clinical practice, research, and education. Today's talk will cover the latest insights, imaging strategies, and evolving treatment options, including the role of vasopressin receptor antagonists, blood pressure control, and supportive care to slow disease progression. Dr. Ibad will guide us through the evolving landscape of adult polycystic kidney disease management, focusing on latest clinical guidelines and their implications for practical approach. Therefore, ladies and gentlemen, please join me in welcoming Dr. Adil Ibad on stage as we delve into the current and future landscape of managing adult polycystic kidney disease.
Thank you very much, Zaira, for such a privileged introduction. First of all, I would like to thank the organizing committee and especially my friend Dr. Sajid Abbasi for making his dream come true we were here last year for some meeting, and then he had this idea, he floated around this idea that there should be a conference at Hill Station. So congratulations for fulfilling your dream and giving me the opportunity and honor to present at this platform. My talk is a very extensive area because ADPKD, or autosomal dominant polycystic kidney disease, is a spectrum of disease. It does not involve kidneys, it involves multiple organs as well. So I will mainly focus on what evidence we have, what studies we have, and what treatment options we have. So ADPKD is a genetic progressive disease, is the fourth leading cause of end-stage kidney disease, and is the most common cause of genetic kidney disease worldwide. As you can see, when the cyst replace the normal kidney, they look like this. It affects 1 in 400 to 1,000 patient, and by age 60, 50% of patients with ADPKD may develop end-stage kidney disease. So this is very important slide. As most of the polycystic kidney disease, they are of two types. So they are two genetic variant, PKD1 and PKD2. And mostly patients, 70 to 80% are PKD1 and PKD2. So as you can see, the PKD1 produce polycystin 1 and PKD2 polycystin 2, which are involved in the cell, controlling cell proliferation or apoptosis. So when those genes produce abnormal protein, there is more cell proliferation, apoptosis, dysfunction, and problem in cell signaling and transduction pathway, as you can see, and there's increase in fluid secretion. So initially there is a dent in a tubule, and that tubule is still connected to nephron. But as it progresses, the cyst fill with the fluid, and then it get its connection lost from the nephron, and it grow and grow, and that causes over time damage to other nephron by pressure as well, and that result in fibrosis and result in progressive kidney disease. Okay, so this is very important from KDIGO guideline. KDIGO have recently published these guidelines in 2025. These are very extensive guidelines. I have taken some important algorithms from KDIGO that are very helpful clinically for all. My senior colleagues are familiar with it, and for my junior colleagues at this platform. So as you can see, if you feel there is a clinical risk and you want to screen, a patient is not genetically already tested, then you need to do the imaging. And then imaging, if it's simple ultrasound, it gives you a diagnosis, it can confirm with the pattern. We go to the diagnostic criteria later on. If it's atypical, then you go with kidney MRI. But nowadays, kidney MRI in most cases is better as compared to ultrasound. If there is already a family history, and we know that there's a family history, then you can do allele-specific genetic testing just to confirm the disease in your patient who have positive family history, because this is 1 into 50. So if patient or parents have polycystic kidney disease, 50% of their children will have this disease. So what to do when there's adult with incidentally detected cyst on kidney, liver, ultrasound, CT or MRI? You need to see if you have any available imaging of family member. If it's positive, we go back on the previous algorithm. If there's atypical presentation on the imaging, and you know it's probably uncertain, then the kidney MRI need to be done, and then you can proceed with the genetic testing, and if it's all equivocal, just monitor with the imaging. If there are multiple cysts, kidneys enlarged, reduced kidney function, liver cyst, and diagnosis confirmed, just you manage. We will discuss on that as well. If there are few cysts, normal kidney function, normal size. Just of note, these, the solid lines indicate that these are suggested by KDIGO, and dashed line indicate tests to consider. So you can consider those tests. This is from 1994, published in Lancet. This was a previous criteria. My all senior colleague would be very familiar with this one, Ravine ultrasonic criteria for diagnosing ADPKD. The difference is when there's a positive family history, you need less number of cysts to get diagnosis, and there is an age cutoff. But I'll go through a recent criteria. This is latest one. If there's a risk of ADPKD, and then it's still divided into age bracket 30 to 59 and more than 60, and then the number of cysts in kidney define the diagnosis of polycystic kidney disease. If they have known ADPKD, then you need less number of cysts to diagnose ADPKD. If they're at risk, then you can use MRI. MRI give you a better clarification and diagnosis. So what is vasopressin? Because this slide is very important here, because we are going to discuss the literature. And in the polycystic kidney disease, there was no treatment a few years ago. Then this drug came, which is a vasopressin receptor antagonist. As most of you would be familiar with the mechanism, that how it works. It works at the V2 receptor in collecting duct. It block V2 receptor and prevent insertion of aquaporin channel in collecting tubule, which result in free water diuresis and also decrease urine osmolality and cause hypernatremia. So this is also being utilized in most cases of hypernatremia as well. So I will say this is a diuretic, so which is also being used and approved by FDA to use in euvolemic hyponatremia and also in hypervolemic hypernatremia. So this is an important trial, TEMPO 3, which have around 1,445 patients, 18 to 50 years. The important thing here is they included all ADPKD patients with creatinine clearance of more than 60 and total kidney volume of more than 75. These are important things which we'll discuss and clarify in next slides. Their primary endpoint was rate of change of kidney volume, and they have secondary endpoint, composite time for clinical progression, to see worsening in kidney function, kidney pain, hypertension, albuminuria. As most of my colleagues and practicing nephrologists would know, that sometimes it's really, really difficult to manage the pain in people who have advanced polycystic kidney disease and cyst infections as well. So probably that's the reason they put it as a secondary endpoint. And then rate of kidney functional decline. This follow-up was for 36 weeks in this one. Then this is TEMPO 4 trial. It was designed to provide an additional 2-year data on long-term safety and efficacy of tolvaptan, who were in the subject completing TEMPO 3-4. The result of TEMPO 4 support a sustained disease-modifying effect. We'll compare these all studies in a later on slide. This is REPRISE. So this is very important study. Probably this study have resulted in the KDIGO to put a recommendation in their guideline. So 1370 ADPKD patient, 18 to 55 were included in a study who have EGFR 25 to 65, and then more 56 to 65 year elderly population, or they will have EGFR till 44. And it was followed for 12 months, and primary endpoint was change in EGFR from baseline to 12 months. So this slide summarizes all three studies. From TEMPO, you can see there is a decline in EGFR, there is a reduction clinically in kidney pain with use of tolvaptan. TEMPO 44 also had benefit of preventing decline in EGFR, and this is a long follow-up. And then REPRISE was a randomized controlled trial, which also showed that people with rapidly declining EGFR, they also benefit from this tolvaptan. So what does KDIGO say? KDIGO recommend initiation of tolvaptan should be offered to adults with ADPKD who have EGFR of more than 25 mils and risk of rapid disease progression as indicated by either Mayo Class 1C to 1E or historical rate of EGFR decline by more than 3 mil per minute every year. So this is definition of rapidly progressive disease. As you can say, there are two approaches. One is the more preferred approach is Mayo classification. There are alternatives to that in few centers. If you're not able to, or the radiologist is not able to give the size, depth, and width of the kidney, you cannot use the Mayo class. We'll see in the next slide that we have calculated kidney volume for a patient. So then you can use this PROP KD score. If it's more than 6, that also show rapidly progressive kidney disease, or there is an increase in total kidney volume. That also require your good radiologist support. So this is a calculator freely available online. You can calculate total kidney volume based on MRI and CT. In the studies, they have used this total kidney volume as a marker to see progression or cyst progression. So these are few views that you will need. The numbers for this calculator, you need width, depth, and then length of the kidney. So we use this calculator and to see, this is example. You can put all these numbers in the calculator online, and then you have to give the height of your patient to adjust height adjusted total kidney volume. So this case, kidney volume is 808 ml per meter, which was height adjusted, which put this patient in Mayo Class 1D. So this is high risk patient. So this is a clinical utility which we can use. And as I suggested that if it is not available, we don't have access to CT, MRI imaging, then we can use PROP KD score. Then this is PROP PKD score. There are points there. If the point is 0 to 3, it's a low risk, 4 to 6 intermediate, and 7 to 9 high risk. So they're all for risk of progression of end-stage kidney disease as the score go up. So once diagnosis of ADPKD is confirmed, and then you have measured the kidney volume by CT MRI, you have classified them based on Mayo classification, and then you have found out that there's a risk of rapid progressive ADPKD, and then they should be started on tolvaptan. Okay. Currently, the people who have a Mayo Class 1A or 1B, they don't need tolvaptan. They need reassurance and just to monitoring every 2 to 3 years with imaging to see if there's a progression. All our nephrologist colleague would know, because other than tolvaptan, all patients need their general management, their lifestyle management, their blood pressure control, their sodium restriction. Even if we increase hydration in autosomal polycystic kidney disease, it also prevent cyst progression as well, even just increasing the fluid intake, 2.5 to 3 liter as well, and then to maintain their healthy lifestyle. There have been other new molecules which have been studied in this polycystic kidney disease, like SGLT2 inhibitor, and other agents which are not promising so far. So tolvaptan reduces EGFR decline, and it is FDA approved only for rapidly progressive, or that's why we came along with all these definitions and all the criteria, that it is approved for rapidly progressive kidney disease with autosomal dominant polycystic kidney disease. So now you came till here that you have diagnosed, you have confirmed the diagnosis, and your patient have rapidly progressive autosomal dominant kidney disease, and you want to do something for your patient. You have option of tolvaptan. What you need to do beforehand? So you just need to make sure you have their baseline liver function, AST, ALT, bilirubin. If they are normal, you can start them on tolvaptan, because it's mandatory to monitor their LFTs while receiving tolvaptan. KDIGO recommend monthly for first 18 months and every 3 months for 18 months, because the benefit is on the long treatment course. If you give this drug for some time, because there is a yearly decline of 2 to 3 ml per minute in EGFR. How you start? So this is the initiation dose. Dose should be started properly. 40 mg in the AM and then usually 15 mg in the PM. It should be 8-hour gap in between them. Then you can titrate up in a 1 week. If they don't have any contraindication, they're not having any side effect, they did not have any changes in their liver enzyme, and they are not on concurrent cytochrome inhibitors. There are a few special situations. If someone have cystic kidney disease, cyst in the liver as well, they might have abnormal liver function. So those are special situations where you can start with the lower doses as well. And then few people, they won't tolerate this dose, then you can down titrate as well. That is also algorithm from KDIGO. So the most common adverse effect we're going to discuss, tolvaptan is not tolerated by 15% patient because of polyuria. Counseling is very important on tolvaptan. Polyuria is often decreased in later stages. Tolvaptan leads to maximally diluted urine, as that's the mechanism of this drug. If someone have near normal EGFR, their urine can go up to 7 liters on tolvaptan. As their disease is progressive or they have chronic kidney disease, they might have urine output up to 5 liters. So patient can get worried. As I said, this is a diuretic earlier as well, so they need to be counseled about it. Adverse effect, hepatotoxicity, is rare. Increase in transaminase is more than 3-fold upper limit of normal in 5% of patients were seen in clinical trial. Increase in generally reversible following. If we hold tolvaptan, they usually go back to normal, and if you reintroduce tolvaptan, it go back up, then sometime there's no option and you have to stop it. This monitoring I have already mentioned in the previous slide. These are contraindication: pregnancy, lactation, liver disease, injury, but stable polycystic liver disease is okay. High level of sodium is in the blood, it is a contraindication, because patient need to have access to water. You won't restrict water when you start them on tolvaptan. Dehydration, and if the obstruction to urine flow is a precaution, it's not a contraindication, and if there's allergy to tolvaptan. This is very important, from NephJC. This will just summarize everything, what KDIGO guidelines say. So these are take home for adults. You diagnose with imaging, then you use Mayo Clinic classification. You target blood pressure of less than 110/75 and measured by home blood pressure monitoring in patient 18 to 49 with CKD stage G1, G2, and high blood pressure target is acceptable in more elderly cohort. Drug of choice is RAS, ACE, ARB, first line therapy to achieve blood pressure target. We commonly encounter these urine infection and cyst infection in ADPKD cohort. Do not treat asymptomatic bacteriuria. just treat the infection with the appropriate sensitivities available on urine culture. Use short-term antibiotic. Less than 7 days is okay for UTI patient, but treat patient who have cyst infection for 4 to 6 weeks with the appropriate antibiotic that penetrates cyst. Not all antibiotic will penetrate cyst, so that need to be considered. If they are going for kidney transplant, they don't need nephrectomies preemptively. They need nephrectomy only in specific cases where there is a severe recurrent cyst infection, if they have symptomatic kidney stones, if they have any severe cyst bleeding, hemorrhage, or there is suspected malignancy or space constraint for graft. So that are indication for nephrectomy. So how we can slow the progression? As we said, tolvaptan is the drug, and increase water intake 2 to 3 liter if eGFR is more than 30. Do not use mTOR inhibitors, statin. They have been tested, but we can use somatostatin analog if they have polycystic liver disease as well. Who needs screening for intracranial aneurysm? Personal history of subarachnoid hemorrhage, family history of ICA, sudden death, unexplained death, or if they are eligible treatment and with reasonable life expectancy, if they need screening. This is for maternal and pediatric consideration from this KDIGO 2025 guidelines. So they say with the ADPKD, if mother is on or patient is on contraception, what to be cautious about that, because estrogens is linked with increase in size of polycystic kidney disease progression, but that does not, because there's other alternate options for contraception. If patient is on tolvaptan or RAS, they need to be discontinued before conception. Genetic testing should be offered to all individuals with a personal family history of ADPKD, and intracranial screening is recommended for women with family history or de novo ADPKD or unknown familial history or history of extracerebral vascular disease. So we know that kidney disease itself increases the risk of preeclampsia, and this is also true with ADPKD, that a patient who become pregnant with ADPKD, they are at more risk of preeclampsia. So they need to be monitored, and low dose aspirin have shown to be effective in other risk of preeclampsia and ADPKD as well. What are pediatric consideration? Because you see these in your clinical setting as well, because we have limited pediatric nephrologists in Pakistan. So their blood pressure target should be low, less than 50 percentile for age, sex, and height, and less than 110/70 in adolescent with ADPKD and high blood pressure. Drug of choice is RAS, ACE, ARB for high blood pressure in children, adolescent with ADPKD. You need to have genetic testing in young children with strong family history. They can be offered genetic testing. Routine screening for liver, pancreas, spleen, cardiac, valvular disease, or IC is not recommended in children, adolescent till now. Avoid vasopressin analog in children with at risk for ADPKD. So this is an important point. So we can use it in adult. It's not recommended in children so far. Thank you very much for listening.
Are there any questions from the audience? Yes. Yes, please.
Thank you very much, sir.
आप उठे खड़े सवाल क्यों करते हैं? बेटा अगर आपको सवाल करने वाला तो मैं बाद में कर लूँगा, अगर है तो ज़रूर करेंगे। मैं बाद में कर लूँगा, ताकि ये ना सोचे कि सर मैं ही कर लूँ। नहीं। अच्छा बेटे, कुछ क्वेश्चन आपके लिए और कुछ मेरे जैसे टीचर्स के लिए हैं जो अपने आप को प्रोफेसर कहलाने में बड़ा प्राइड फील करते हैं। मतलब ज़रा ध्यान से सुनिए, मैं प्रोफेसर साहबान भी, आपने बेटे कल को प्रोफेसर बनना है। بیٹے ایک تو آپ نے کہا کہ ورلڈ وائڈ دس از دی فورتھ امپورٹنٹ کاز آف اینڈ اسٹیج رینل ڈیزیز. شفا میں یا باقی پاکستان میں آپ کی آبزرویشن کیا ہے؟ میں ذرا تھوڑا سا اس سے اختلاف ہے, پتہ نہیں میرے کو یہ کیا کہتے ہیں.
I think this data is probably old from 2018, so I might agree with your comment. We don't have our own data from Pakistan as far as I know.
اچھا ویسے آبزرویشن بیٹے کیا ہے؟ میں بتاتا ہوں میری آبزرویشن کیا ہے. میں ڈاکٹر منصور کو دے رہا ہوں السلام علیکم. میری آبزرویشن یہ ہے کہ آج سے 40 سال پہلے جی این ہوتا تھا نمبر 1, اب حالات بدل گئے. اب ڈائبٹیز دنیا میں بھی اور پاکستان میں بھی
Yes.
نمبر 1. نمبر 2 ہائپر ٹینشن.
Yes.
نمبر 3 جی این. اور میرے خیال کے مطابق نمبر 4 بیٹے اسٹون ڈیزیز ہے. ایک اپنے آٹوسومل ڈومیننٹ نہیں ہے. اٹس امپورٹنٹ بٹ ناٹ نمبر 4.
This is the
I think
مجھے پتا آپ کی آبزرویشن کیا ہے.
I agree with you. Probably in Pakistan, the stone burden and stone disease
Thank you
is,
very much. So let's cut it short. Let's go to the next question.
and worldwide probably that is true.
ٹھیک ہو گیا, ٹھیک ہو گیا. آپ نے ایسٹروجن کا ذکر کیا کہ اگر آپ وہ کنٹراسیپٹیو یوز کریں تو پروگریشن کی سپیڈ بڑھ جائے گی. اب میل میں تو نارملی ایسٹروجن ہوتا نہیں ہے انلیس یو ڈیولپ سروسس. اسی صورت میں آتا ہے نا جس کی مینیفیسٹیشن ہوتی ہیں. گائنیکومیسٹیا ہو گیا, وہ کمیونیکیشن جو ہے وہ کھول گئے. اچھا تو آپ کیا آپ کی آبزرویشن ہے یا کیا پڑھا آپ نے کہ فیمیل میں اس کی پروگریشن زیادہ ہے ایز کمپیئر ٹو میلز؟
This is the risk associated with estrogen.
بیٹے میں کہا نارملی بھی فیمیل میں ایسٹروجن ہوتا ہے کہ نہیں, بات تو یہ ہے.
Yes.
All of them have estrogen. اور you don't have to wait for post menopausal. یہ تو ارلی ہو جاتی,
I think
ارلی آ جاتی ہے.
there is no studies جس میں انہوں نے کمپیئر کیا ہو کہ فیمیلز میں یہ زیادہ ہے یا میلز میں پروگریشن زیادہ ہے. ابھی تک اس پہ کوئی نہ آپ کی ایتھنیسٹی افیکٹ کرتی ہے. یو کین اسٹل ہیو اے ڈی پی کے ڈی اف یور سیکس میل فیمیل ایکولی.
چلو پھر میری سجیشن ہے اگر مجھے موقع ملے تو میں کسی یورپین کو یا امریکن کو پوچھوں گا, اگر آپ میں سے کسی کو موقع آپ ضرور پوچھنا. مطلب دیکھو نا کہ ایسٹروجن کا اگر افیکٹ ہے تو پھر نارملی بھی جو ڈیزیز کا کورس ہے یہ اٹ شوڈ بی ریلیٹیولی ریپڈ ان کیس آف فیمیلز ایز کمپیئر ٹو میلز. ہونا چاہیے.
So far no, there is no evidence.
میں کہتا ہوں یہ ہمارے موقع مل گیا نا. مطلب اگر کوئی امریکن یا یورپین کوئی پریزنٹیشن دے رہا ہے تو وی کین اسٹینڈ اپ کر پوچھ سکتے ہیں.
I think we probably need data from Pakistan at this stage with the young nephrologists around.
بیٹھے یہ مذرا ویٹ کریے, آئی ایم کمنگ ٹو دیٹ. یہ کسٹم ہے, یہ بڑے نیشنل کانفرنس ہو رہی ہے, ٹھیک ہے نا. تو مجھے نہیں پتا پروگرام کا کیا ہے, میں نے دیکھا نہیں ہے. آئی ول بی چیئرنگ ون آف دا پروگرام, میں نے وہ بھی نہیں دیکھا. یہ بڑے انفارچونیٹ ہے کہ ہماری جو زیادہ تر پریزنٹیشن ہے نا وہ بڑے ریویوز ہوتے ہیں, ہماری اوریجنل اسٹڈی کوئی نہیں ہوتی. اگر ہوتی تو بہت کم ہوتی. انڈین ہمارے مقابلے میں بیٹے بہت آگے ہیں. وہ جنگ ہار گئے لکیلی. گڈ لک فار پاکستان. ادروائز جہاں تک اکیڈمکس کا تعلق ہے آپ سارے ایگری کریں گے بیٹے وہ ہم سے بہت آگے ہیں اور ہمارے لیے بہت بڑا سوالیہ نشان ہے. ٹھیک ہے. اور یہ ہے بیٹے سول سرچنگ فار پیپل لائک می. وہ ڈاکٹر ساگ صاحب ہیں, آغا خان میں بھی رہے ہیں. ایک دفعہ ان کو آنے کا موقع ملا, ہی گیو اے پریزنٹیشن اس میں پنجاب میڈیکل کالج میں. تو بڑے لوگوں کی باتیں میرے جیسے لوگوں کو کبھی کبھی یاد رہ جاتی ہیں. تو انہوں نے ایک فقرہ بولا کہ ان آرڈر ٹو بی پروفیسر یو ہیو ٹو پروفیس. یہ گھر جا کے سوچنا کہ اس کا مطلب کیا ہو. اور یہ میری ریکویسٹ ہے سینئرز کے لیے کہ اس کلچر کو تھوڑا سا پروموٹ کرنے کی کوشش کریں. آئی ڈو ایگری کہ گورنمنٹ کی پالیسی کنڈیوسو نہیں ہے فار ریسرچ, لیکن ہم نے وہ لمیٹیشن میں رہتے ہوئے بیٹے ہم نے لمیٹیشن میں رہتے ہوئے آئی بلیو کہ ہم پھر بھی کچھ کر سکتے ہیں. ڈونٹ ٹیک اے, سچی بات ہے. آئی ایم پراؤڈ ٹو ہیئر کہ جہاں اپنے بیٹے بیٹیوں کے درمیان, اور یہ میری خواہش ہے کہ بیٹے میرا سیٹ اپ پاکستان میں اگر سب سے چھوٹا سیٹ اپ رہا ہے تو وہ ڈاکٹر طفیل کا رہا ہے. اور میری پوسٹ بھی نان پروفیسر ہوئی. مجھے لوگ لکی دیانا پھر لوگ مجھے پروفیسر طفیل کے نام سے ہی پکارتے ہیں, لیکن بیٹے میں پاکستان میں ایز پروفیسر اور پیپرز کبھی بھی نہیں رہا. لیکن اس کے باوجود امریکہ میں ضرور تھا میں. بیفور آئی ڈیسائڈ ٹو کم بیک ٹو پاکستان آئی واز ایسوسیٹ پروفیسر ان آلریڈی میڈیکل کالج. اچھا تو بیٹے اسمال سیٹ اپ کے باوجود وی ور ایبل ٹو پریپیئر 3 پیپرز, اور وہ بیٹے اوورسیز پریزنٹیشن تھی. ہم ایشیا ایشیا کانگریس آف نیفرولوجی ڈاکٹر سمی صاحب میرے ساتھ گئے تھے, اپنے وہ تھائی لینڈ میں اکٹھے سفر کیا, اٹ واز ویری پلیزنٹ جرنی. اور دوسری 2007 میں جو ایک بڑی اپنا آنریبل فورم ہے فار نیفرولوجی, ورلڈ کانگریس آف نیفرولوجی, فیصلہ آباد سے بڑی پریزنٹیشن تھی, آپ کو خوشی ہوگی. تو میں سمجھتا ہوں کہ آپ لوگ بہت کر سکتے ہیں, آپ انڈر ایسٹیمیٹ نہ کریں. کیا مزہ آئے گا کہ امریکن آپ ایک پریزنٹیشن دے رہا ہے, 2 سوال اٹھ کے پوچھ رہے ہیں, وہ جواب کر دیتے ہیں. کیا پرائڈ ہوگا میرے جیسے لوگوں کے لیے. اس لیے بیٹے جب آپ گھر جائیں نا بیٹے, پریکٹس بھی ہے لیکن منی کو بیٹے وہ آپ مقصد نہ بنائیں, اس کے بغیر بھی بڑے پیسہ آپ کے پاس آئے گا. ٹھیک ہے, آئے گا, لیکن اگر پیسے کی ہوس سے آپ کو لے لیا, جو انفارچونیٹلی بیٹے آج کل پاکستان میں دیکھ رہا ہوں, اللہ تعالیٰ یہ کرے میری زندگی میں یہ بدل جائے, تو بیٹے حالات اس سے بھی زیادہ گر جائیں گے. میں نے کہا یہ آپ آئیڈیا دے دو, شاید کچھ آپ سوچیں اور اس کے بارے میں کچھ کر سکیں. یہ میری بڑی گڈ لک ہوگی اگر مجھے رزلٹ مل جائے اندر نیکسٹ کمنگ ایئر.
Adil, want to ask you a question, whether I misunderstood you or not. You mentioned, because our traditional teaching has been, when I was trained, that in polycystic kidney you restrict water intake. Here you mentioned that you want to, is it because you are putting the patient on tolvaptan because of the polyuria, or just
when you are giving?
So, there are both ways. The answer is, if you are giving them tolvaptan, you don't need to restrict them, you need to give extra water. Yes. So what happens if you give a patient who is not on tolvaptan, you let them drink 2.5 to 3 liter, they won't put aquaporin channel in the collecting duct. Okay, so we are doing the same mechanism with tolvaptan. We are blocking the absorption of free water. Okay, so there won't be any ADH secretion, won't be any free water. So that's the mechanism.
Dr. Adil naam hai.
Adil. Yes.
ایک آپ نے کمنٹ اس میں دیا تھا کہ 50% کو ہوتی ہے فیملی ہسٹری میں, اگر ہو تو 50% چانس ہوتا ہے.
Chance, yes.
میں کہتے ہیں یہاں اسٹوڈنٹ بیٹھے ہوئے ہیں,
Yes.
کچھ ہوں گے تو 50% چانس ہے.
Exactly.
ایسے 4 ہے تو لازمی نہیں 2 کو, 3 کو بھی ہو سکتی ہے, 1 کو بھی ہو سکتی ہے.
Yes, the chances, yes. So in genetics we go with chances. Yes, 50-50.
Any autosomal dominant is any.
Yes.
Chance. دوسرا میں یو کے میں تھا انسٹیٹیوٹ آف نیورولوجی میں, تو ڈاکٹر گائے نیل تھے وہاں, وہ بھی انٹرسٹڈ تھے آٹوسومل ڈومیننٹ کی ڈیزیز میں. تو چونکہ آپ بھی انٹرسٹڈ ہیں سر, آپ آنسر کر سکیں. ہی ٹولڈ می ون ڈے کہ جی ہم نے یہ اسٹڈی کی ہے کہ جو سسٹ میں فلوئڈ ہوتا ہے اس میں اینٹی فریز سبسٹنس ہوتے ہیں, جو کہ اینیملز میں ہوتے ہیں, جو کہ برف میں اور ٹھنڈے حالات میں رہتے ہیں, تو بلڈ ان کا فریز نہیں کرتا. تو ان سے میں نے پوچھا اس کی امپورٹنس کیا ہے, وہ کہتے ہیں مجھے ابھی امپورٹنس کوئی نہیں پتہ, لیکن یہ ڈیٹیکٹ کیا ہم نے کہ سسٹ آٹوسومل پولیسسٹک کڈنی کی سسٹ میں فلوئڈ میں اینٹی فریز سبسٹنس ہوتی ہیں.
I think this is new information for me. اس میں صرف واٹر ہوتا ہے, cysts they are filled with the water because kidney میں anti freeze I don't know.
نہیں, فلوئڈ میں
اور جو فلوئڈ
ان کو بھی پتہ نہیں تھا کیوں ہے, کہتے ہیں لیکن ہم نے یہ
جو ابھی تک اسٹڈیز آئی ہیں, یہ سسٹ ایسپریٹ کرتے ہیں تو اس کی کنسسٹنسی آپ کی سیرم کی طرح کی ہوتی ہے, وہ ہوتا ہے. اینٹی فریز کا تو میرا نہیں خیال, آئی ڈونٹ نو.
جی جی.
ویپٹان کا جو سائڈ افیکٹ ہے پالیوریا, دیٹ از ویری کمبرسم ڈسٹریسنگ فار دی پیشنٹ. سو اٹ افیکٹ دی کمپلائنس آف دی پیشنٹ اینڈ دی کلینکل ایفیکیسی ود اٹ.
یس, if patient is not compliant with tolvaptan due to polyuria, obviously you won't get the benefit of cyst halting cyst progression.
So you recommend it for 15 to 55 years, not more than 55 years. بچوں میں تو آپ ایسے کہہ دیا.
ہاں, بچوں میں ابھی تک ریکمینڈڈ نہیں ہے, نہ کوئی اسٹڈیز ہوئی ہیں. کینیڈا میں بھی ہماری جو اسٹڈیز ہیں جو آتی ہیں وہاں سے, اس میں بھی بچوں کی نہیں ہیں. کچھ میں کی تھی انہوں نے, اٹ واز انکنکلوسو, لیکن بچوں میں ریکمینڈڈ ابھی نہیں ہے. اڈلٹس کے لیے ریکمینڈڈ ہے.
55 پلس میں کیوں نہیں ہے؟ پرابلی کوئی اس کا ڈیوریشن اتنا ہے کہ افیکٹ نہیں ہوگا, یا کیا کوئی سم تھنگ
55 کے اوپر بھی آپ دے سکتے ہیں, 65 تک دے سکتے ہیں.
اچھا.
Sorry, Dr. Adil, thank you very much for an excellent overview. दो तीन चीज़ें तो आई थिंक even if the patient is not on tolvaptan, they have to increase their fluid intake.
Yes.
Because that reduces the cyst progression.
Exactly.
जो मैं पूछना चाह रहा हूँ, जो आपने दो तीन स्टडीज़ प्रेजेंट की ना, द प्रैक्टिकल क्वेश्चन, बिकॉज ये सारा कुछ जो आप बता रहे हैं, इट्स वेरी डिफिकल्ट टू बी डन इन पाकिस्तान टू स्टार्ट समवन ऑन द ड्रग. सो वो तो कंट्रोल्ड इन्वायरमेंट में वो कह रहे हैं कि रैपिडली प्रोग्रेसिव जो हैं, शायद उनका इंक्लूजन क्राइटेरिया वो था, सारी चीज़ें उसमें दे दें, उसमें वो स्लो डाउन करेगी प्रोग्रेशन. But why not in those patients जहाँ rapid progression for example नहीं है, if the pathophysiologically at the end of the day it is going to reduce the progression of the kidney disease, so why can't we give it to those? Is it just because the study population was not, or there is something else? And the second thing is for how long? For how long you would give? Because if you start someone tolvaptan at the age of 30, because over the years आप बता रहे हैं कि GFR progression इतनी slow होगी, so for how long we will give? Just we will follow the study protocol जितना अरसा उन्होंने दिया, या कब तक देंगे?
Okay, so there are two parts of this question. The first study which I presented, Tempo 3-4, in which they have used the people who were not at risk of aggressive decline. So they have seen the decline. So yes, technically we use it because in KDIGO they have not recommended it, but we have evidence that it halt the progression of cyst from the studies, Tempo 3-4 and 4-4. So I think we can use it. Okay, but not recommended by KDIGO so far. They have recommended only, probably it's very expensive abroad. There is a program, we have to get approval and there need to be strict criteria who go on tolvaptan. Asif might know in US there's a strict criteria as well, you need approval. So here if we have an option, luckily we have now tolvaptan available in Pakistan, so we can use it. It's not, previously there was a problem, maybe last year we don't have tolvaptan, but now we have tolvaptan available in Pakistan. So I think we can use with the people, but still we have to pick up our cohort.
उसमें डॉक्टर जाहिद का जो पॉइंट है 1A 1B में क्यों नहीं यूज कर सकते? So you have to give persistently over the period of time to gain some benefit.
Yes.
So what is the average time you have to give 4 years of tolvaptan to save 1 year of ESRD? तो वो कहते हैं कि 24 साल अगर टोलवेप्टन दे तो उसकी ESRD डिले हो जाएगी. अगर मीन एज ऑफ ESRD इन टाइप 1 PKD इज 54 to 56, तो 62 में जाके होगी. तो उसमें 1A और 1B में उसका फ़ायदा नहीं सामने आया.
एविडेंस नहीं है, बिल्कुल.
इस तरह डॉक्टर हलीम का जो क्वेश्चन था कि 55 से ऊपर क्यों नहीं दिया, तो 55 से ऊपर अगर नॉर्मल रीनल फंक्शन है तो वो ज़िंदगी में बाकी भी उसके चांसेस हैं कि वो नॉर्मल ही रहेगा. ही विल नॉट गो इनटू ESRD. लेकिन अब ओपन लेबल एक्सटेंशन जो रिप्राइज की आ गई है, दैट हैज़ मूव द एज टू 62 years old, एंड दे आर नाउ यूजिंग इट. एंड द एक्सपर्ट्स इन दिस ADPKD, Fuad Shabib from Mayo Clinic, and number 2 this Peter Harris, they are recommending, if you have, just like case inhibitors, if you have started them before, for example, GFR 59, 57, they are coming, you take them to ESRD, do not stop that.
Yeah.
But if you want to introduce, don't introduce them at a GFR less than 25.
Yes.
Because then you will not get you have to give persistently over the long period of time. You need to have sick holiday days with that.
Yes.
मरीज ट्रैवल कर रहा है, लॉन्ग डिस्टेंस फ्लाइट है, वो एक्वायूरेसिस के लिए, यूरिन के लिए बार बार बाथरूम में कैसे जा सकता है? उसका लाइफस्टाइल कैसा है कि वो टोलवेप्टन को टॉलरेट कर सकता है, करें. तो उसके बाद कमिंग टू द लास्ट क्वेश्चन ऑफ डॉक्टर तुफैल, in adult polycystic liver disease, because estrogen, as beautifully alluded by Adil, was for more in the polycystic liver, that it causes the progression of polycystic liver disease. So adult polycystic liver disease, which is a totally different disease as compared to ADPKD, their progression in females is faster. And similarly in this disease, because as we know in the pregnancy there's a surge of estrogen, repeated pregnancies in patients with adult polycystic disease, they have a faster progression as compared to the others. हाँ जी, वही उसी की पहली की उसकी मैंने एडल्ट पॉलीसिस्टिक है ना, उसमें प्रोग्रेशन फीमेल्स में फास्ट है.
अच्छा बेटा, दूसरा डिस्कशन बहुत ज़बरदस्त हुई है, लेकिन कुछ चीज़ें फिर भी मेरे ख्याल में रहेंगी, जैसे ना डार्क एरिया. अब ज़रा कंट्राडिक्शन आ रही है, देखो ज़रा, ये जो सिस्टर सारी की सारी कम्युनिकेटिव होती हैं, कम्युनिकेट करती है ना, मतलब क्लोज कोई नहीं होती, मतलब दे कम्युनिकेट विद ट्यूब्यूल्स, उसी का पार्ट डायलेट हो जाता है,
They get separate from
हम उसको
tubules
सिस्ट
later
कहते
on.
हैं, सिस्ट कहते हैं। इंक्रीज्ड वाटर फ्लो से आप मुझे ये बताएं कि ट्यूबुलर प्रेशर बढ़ेगा कि कम होगा?
नहीं, मैंने जैसे मैकेनिज्म बताया है उस स्लाइड में, फर्स्ट देयर इज अ इंडेंट, देन एज इट ग्रोज it get disconnected from nephron. Okay, so cyst is independent. कम्युनिकेट नहीं करती, हाँ कम्युनिकेट बाद में नहीं
आज से
करती।
25 साल 30 साल पहले ना एक स्टडी आई थी, वो बाद में लगता वो उसके रिजल्ट अच्छे नहीं मिले होंगे, वो उसकी फॉलो अप नहीं आया, कि इन पेशेंट्स को पहले ही थायराइड डाययूरेटिक्स शुरू कर दो, इनकी वाटर फ्लो ठीक रहेगा, वाटर फ्लो नहीं उनका नहीं बढ़ाना, मतलब वाटर इनटेक नहीं, थायराइड डाययूरेटिक्स शुरू कर दो, फ्लूइड का वो फ्लो बढ़ जाएगा तो इंट्राट्यूबुलर प्रेशर कम रहेगा तो सिस्ट की जो ग्रोथ है वो कम होगी। देयर कॉमन सेंस तो बनती है, लेकिन बाद चीज़ें कॉमन सेंस को जो होल्ड करती हैं वो ट्रू नहीं साबित होती। सो दिस इज वन ऑफ दोज।
ग्रोथ सिस्ट पे तो उनका कोई इफेक्ट नहीं,
तो ऑब्वियसली होगा।
वो सिस्ट सर बढ़ेगी जिस सिस्ट में फ्लूइड की सिक्रीशन होगी, सिस्ट में अब ये साड़ी किस तरह होती है, वो सिस्ट बढ़ती जाती पेरेंट का खत्म हो जाता है। हाँ, कंप्रेशन की वजह से ये नॉर्मल वो जो उसमें वो मेरे ख्याल इसी में भी शायद दिया होगा कि 4 सिस्ट 3 सिस्ट 5 सिस्ट इस तरह ग्रोथ वो CKD5 में चली जाती है।
एग्जैक्टली, जब सिस्ट प्रोग्रेशन होती है उसका प्रेशर इफेक्ट है। हाँ,
सिस्ट में फ्लूइड को CFTR रेगुलेटर जो प्रोटीन है,
हाँ
उसके कितना अच्छा आपने पहला दिखाया।
बिल्कुल, वो मैकेनिज्म ही वो है, इसके वही मैकेनिज्म है, जेनेटिक, सेल प्रोलिफरेशन और फ्लूइड सिक्रेशन, फिर एप्टोसिस का भी है, तो ये ऑल मैकेनिज्म है। तो आप कह रहे हैं शायद वो स्टडी फिर नेगेटिव होगी पुरानी, क्योंकि वो अब नहीं है उसमें।
इसीलिए तो SGLT inhibitors does not make any sense in patients
Yes,
with
they
polycystic
tried SGLT2 inhibitor, they tried metformin in this as well, nothing worked.
Thank you very much. I think we had a very interesting discussion, and the session was very illuminating, very interesting, and
thought provoking.
And with Professor Tufail's presence has heightened the level of
Thank you very much.
intellectual discussion. Thank you very much, and again thanks to the organizers, and special thanks to Professor Sajid Abbasi for having his dream come true. Thank you.
Thank you, Dr. Adil. As the panel of experts said, it was thought-provoking, interesting, and very illuminating for the audience. Now, this marks the end of today's section. It also marks a historic moment where Pakistan Society of Nephrology has introduced an official tie for PSN members, an important milestone, one that signifies unity, pride, and the transition into a new chapter. It represents responsibility, belonging, and the values we uphold in our institution of Pakistan Society of Nephrology. Therefore, we will now be formally inaugurating this PSN tie. I request Dr. Sajid, General Secretary of Pakistan Society of Nephrology, and Dr. Zahid Nabi, President of Pakistan Society of Nephrology, to present first tie to Dr. Sami J. Rahman, Chief Patron of Pakistan Society of Nephrology. Next, I would like to request Dr. Sajid to present next tie to Professor Tufail.
तुफैल तां टाई नहीं पा के आए सो पता सी इत्थे मिल जानी।
नहीं पता किस खुशी में दी जा रही है बेटे आई लव यू
अच्छा
ऐसे ही रहने दे ठीक है बेटे ऐसे लोग हमारे लिए प्राइड है और जो मैंने कहा है बेटे मैं दोबारा कह रहा हूँ कि मुझे आप में वो ना कुछ चीज़ नज़र आ रही है हिडन कि अगर आप इसको कोशिश करेंगे तो इंशाल्लाह मेरा जो है ना मेरी दुआ पूरी हो जाएगी
वैसे और भी हिडन वो हैं टैलेंट्स हैं ना
And although Dr. Brigadier Halim is wearing one, but we would like to give one to him as well.
Now it's time for the shield distribution.
I wanted for Professor Dr. Zaid Nabi as well, लेकिन वो शलवार कमीज पहन के आगे इसलिए हम नहीं कर सके प्रेसिडेंट के लिए
I would like to request Professor Dr. Zahid Nabi to distribute the shield among the panel of experts. Dr. Sami J. Khan, please come on stage to receive your shield. Dr. Brigadier Halim, please come on stage. And Dr. Syed Munib, please receive your shield.
Thank you so much, Dr. Zahid Nabi. Now I would like to request Professor Dr. Tofail to please present shields among the speakers of today. First, Dr. Sajid. A huge round of applause for the organizer of our conference. Dr. Tofail, please present the shield to Dr. Raja Asif. Clapping.
कंटेंट भी अच्छा हो, प्रेजेंटेशन अच्छी हो, अंग्रेजी अच्छी हो, ऐड कलर टू इट। मैं ये नहीं कहता बाकी को नहीं थी, इसे आपकी बहुत अच्छी।
Very nice. A huge round of applause for Dr. Tofail and Dr. Okay, sir, one more. Dr. Tofail, please stay. Please stay. Dr. Tofail, please present the shield to Dr. Adil Ibad.
इनको मैंने बहुत सवाल पूछे। लेवड़े बहुत अच्छा। लेवड़े बहुत अच्छा था। आपकी प्रेजेंटेशन बहुत अच्छी। मेरी आपकी परफॉर्मेंस बहुत अच्छी।
Thank you, sir. Thank you so much to everyone for joining us today. Hope you all learned something from our sessions today. And now this marks the end of our session. Enjoy and please join us for dinner. See you tomorrow. The dinner will be served at 9 p.m. तब तक please enjoy the weather. The dinner will be served at 9 p.m. तब तक please